Alors je suis sur scène en compagnie de Diane Muhongerwa, qui est économiste de la
I am here with Diane Muhongerwa. She's an economist at the WHO, and Guy Patrick Obiang, who's the Deputy Managing Director of the National Health Insurance and Social Welfare Fund in Gabon, Vale, Ridde, an Associate Professor at the University of Montreal and a member of the Canadian Institute of Health Research, and Chris Atim.
Not a medical doctor, Monsieur Chris Atim, qui est expert en financement de la santé.
He is an expert in the financing of health.
Economics and Policy Association. Je précise que vous avez aussi présidé au comité de revue.
I would also like to add that you have been an active member of the healthcare industry in Ghana. We are going to be talking about universal healthcare in Africa and the problems, the key issues at stake, and development perspectives. It is obviously a key issue of public health, but nobody managed to actually find a magical recipe in order to finance it. So we're going to try to analyze the various models that have been implemented. So Chris and Valerie, Guy Patrick, also I believe that your main areas of expertise are rather clear for the people who are listening to us. Diane, maybe you could talk to us briefly about what are the activities, the main activities of the WHO in Africa.
Thank you very much. WHO, we support mainly in Africa, countries to understand their socio-economic context, identify their needs. We know that now we are in the SDGs era where there's a need for more inclusivity, leaving no one behind, and with a greater scope, much larger scope to cover, which involve more innovative strategies to mobilize adequate resources. So we support countries to understand their contexts and also health financing challenges. We know that in Africa, many countries are developing. They are relying on external aid with sustainability issues. So we support countries to understand their contexts and define strategies. It's not a matter of like increasing resources, but we focus on universal health principles where everyone has to access. So we support countries to develop strategies in terms of financial risk protection, and universal health coverage is not a destination, it's a path. No one has achieved it, but progress, we need to start from somewhere. WHO also support countries to manage or to identify strategies for an efficient management of the available resources with reduction of inefficiencies, fragmentation, and also resource use, strategic purchasing, etc., etc. These are the key functions of health financing in which we support the countries to incorporate in their policies and also follow up the implementation. This has to be accompanied by strategies in terms of accountability to ensure that it is implemented. And in WHO, we also think that universal health coverage can't be attained without resilient systems. So health systems need to be built because without them, the UHC can't be achieved. And specifically, the other building blocks of the health systems such as governance, are very key to the success or the sustainability of universal health coverage. We need good policies, good laws in place, of course implemented, and good plans so that we can mobilize resources. We need human resource, especially the capacity in human resource to conduct health financing functions is a problem in Africa. So we need to sensitize or to support countries identify the needs in developing human resource capable of managing. And also health information is very key. We were talking about health insurances. We need to have ways of having good data on how they function, etc., etc. So, and institutional arrangement. We need to separate functions, providers, insurers, etc., etc. So we need really to clarify all those things. But all in all, we support countries to strategies, innovative strategies like domestic resources which are more reliable, but it's a challenge to have them, to identify based on socio-economic context, identify what can work, and also more efficiency, more partnership with the private sector, which is an area which was not really well explored, but can be another source of domestic financing, etc., and also strategies in strategic purchasing as we use the services. Thank you.
Okay, I will just stop you there because first of all, you have to keep some stuff to say for the rest of the conversation because we would like to keep on hearing you. And also I'd like to start broaching the main topic here, which is financing. The first thing we can say, en français, la première chose qu'on peut rappeler, c'est que le principal
in French is that the first problem that Africa has when it comes to implementing the universal healthcare coverage is the portion of the informal sector, which can be over 60% of the coverage in some countries. In such conditions, how do you have a contribution level that is sufficient? And I'd like for us to do the following, and I apologize if some of you are experts and it might be redundant for some of you, but to actually describe the landscape of financing in this field in Africa the way they currently are. Who wants to take the floor? Chris.
Thank you. Actually, I should protest. I thought that there is one Anglophone in each panel.
It's supposed to be on. I think it is.
It's supposed to be, yeah?
Yes.
Okay, great. It's supposed to be one Anglophone in each panel, and I'm the Anglophone. So I don't understand why Diane took my place. You should be speaking in French.
Yeah, we can do it the other way around. You can speak in French. Please go on.
Okay. Yeah, no, this is a good question, actually. There are the to take the your more general point about the different ways of funding the health system in Africa. Obviously, you have the communities, you have government, you have development partners, you have even companies through and workers through social contributions and so on. There are many ways of funding the health system, but I think the most interesting thing is rather part of your question is how do you fund the informal sector who are not in a way as easily captured in social systems and payment systems that you can quickly and easily obtain their contributions. And that is where I think that the original contribution of mutuals in Africa has been, in that they showed what the state thought was impossible. That is how to get the informal sector involved in social security systems. They showed that it is possible actually to organize the informal sector to make some contributions. That's one thing. The second thing is that is at the level of the community, that's fine. But in terms of social health insurance and universal health coverage, I think it is an illusion to think that you can actually depend upon contributions from the informal sector as they exist today to fund an elaborate system of health of welfare coverage, I think you'll have to realize that there's a very big role for the state to play in actually covering the informal sector, particularly people who are vulnerable and those who are poor and so on. It is the principal responsibility of the state to actually cover those. Now the question is, what are the mechanisms that the state can use to do that? The general tax revenue being as it is, having so many objectives. I think that people are talking, it's in that context that people are talking more and more about what they call the innovative financing, which I personally think is misleading, because I think innovative financing actually, in case of Ghana, for instance, we have a VAT, which is 2.5% of VAT is put on is put on to fund the healthcare of those who are not making a direct contribution. The formal sector makes a direct contribution, but the informal sector does not. So 2.5% is put on to fund those people. But it has made the system perverse in a way.
In what way?
In the way that, okay, first of all, it's an earmark tax. Ministry of Finance don't like earmark taxes. So the Ministry of Finance is finding ways to undermine the earmark tax. At the time, it was politically convenient for the government to do so when they put it on, because there was an IMF pressure to increase the VAT, and there was general opposition to increasing the general VAT. There was even the party in power at that time had led demonstrations against increasing VAT. So they couldn't do that when they were in power. What they did, which was very clever, was to say, we're not increasing VAT, we're just putting on a tax to pay for health insurance for people who cannot pay for it. And that was more acceptable. Now, that meant that we are reliant on an earmark tax. The current Ministry of Finance is against the earmark tax. What they are doing is undermining the funding of the rest of the health sector. So the funding overall to the health sector in Ghana has been declining because other areas of the health system are not being funded to the extent they were funded before. The Ministry of Finance are giving that you have got VAT dedicated to health. So that's one risk. The other one is that it's giving the illusion that you can pay for the coverage of the population through an earmark tax. But in traditional health insurance systems, people pay a contribution, in the classic system, pay a contribution when they join. So the more people you have, the more revenue you have to be able to cover your expenses. But VAT is not related to the number of people in the scheme. It is a tax on sales. It's not, so for the beginning, for instance, in Ghana, the VAT was sufficient, largely sufficient for the number of people in the scheme. But as the scheme numbers grew, the VAT remained basically constant because it depends upon the growth of the economy and not the number of members. So, and the economy, in fact, actually was also declining in many ways. The growth was declining. So you have a perverse situation where the revenue for the VAT was going down as membership was increasing. That's the problem. So there are those kinds of issues that arise with so-called innovative financing. I think that it's better to talk about smart financing rather than innovative financing.
I get that. Si on parle de smart financing.
Now, talking about smart financing, and I'm going to ask Mr. Obiang, does that mean that you're referring to the social security system that was implemented in Gabon because it is specifically financed by a tax on phone operators? Thank you very much. First of all, I would like to thank the Pierre Fabre Foundation for the support to the National Healthcare Agency of Gabon. Indeed, as far as we're concerned, we started in 2002 when we needed to completely change the system, and the question was, what is currently the essential element that means that we can have a social impact on the well-being of the population? Health was the answer, and that's why we started working on this. All these mechanisms that were actually created by Bernard Kouchner in 2002 to create our social security system in 2007. First of all, we started with the poorest. Some data was gathered in order to get simulation and projections on how much health could actually cost depending on the target. We talked a lot to unions, employers, workers' unions, etc., because it was very difficult. No one wanted to spend 1 cent to fund social security and health. There was a lot. Everybody was unwilling to actually change the system, the social welfare system. We thought that the industries that would have an impact on the health of the population, like beverages and tobacco, could actually fund that. They actually said, no, we already are spending quite a bit of money to subsidize health. So we turned to the oil sector, because we are an oil producer, and we asked the oil producers to finance health, the health system. They said, well, you know what, we signed an agreement with the Gabon government on fiscal stability clauses, so nothing can change. We're not going to accept that the taxes go up. And that's when we actually discovered with the tax experts who helped us in the ministries that there was a sector that had a lot of financial potential. It was the phone operators. And with the willingness of the political elected officials, we actually decided that. How did it happen? It worked extremely well at the very beginning, because at the beginning there were actually few people who were registered, and when you increase that, the expenditures increase depending on the revenue. And quite quickly, we ended up with expenditures being higher to the revenue, to the income, because of the economic crisis. We used to have 4 phone operators who financed everything, who financed the expenditures of the poorest, but with the current oil crisis, out of the 4 phone operators, 2 of them went bankrupt, and only 2 of them actually are continuing to finance it, and it's becoming difficult for them. So we are going towards the creation of a social VAT on consumption in order to meet the need of financing for the poorest. I'll get back to you, but for the time being, maybe you could actually tell me if the coverage actually improved and where we stand right now. But Valerie, in the meantime, I know that you actually had studies in Burkina Faso where you actually realized that those who earn the most having to pay for the rest of the community, that is something that is difficult for the people to accept. Correct, because you're talking about values and choices for society. When you decide in a society or in a Ministry of Health to actually create a universal coverage, for instance, with a private insurance company that is on a volunteering basis, it just doesn't work. And it's been the case for 30 years, but at the same time, you need to actually want to do it at the political level. And I remember that in Gabon, before this tax on devices and text messages, Gabon actually managed to gather a lot of money in order to actually send the soccer team to the Africa Cup of Nations. So we had actually managed to gather a lot of money in order to finance some things, but not others. It just shows that when you want to do something, you can actually achieve it. Now, the question of values is a complicated one in our society and in all societies, to understand that ultimately one day you're going to have to pay for somebody else. And that's difficult. You need to be able to understand the social values where you are in order to create a financing system for health, making it possible that everybody's going to benefit from it. And this is exactly what we saw in Burkina Faso. When you ask people to actually pay for somebody else who didn't pay for it, it was difficult for them to accept that. And there was a study in the northern part of the country. It was a very hierarchical and pyramid kind of system where everything needed to be shared equitably, not with equity. And that's with equity rather not equitably, and a lot of people still don't make the difference. So ultimately we need to get back to the capability of financing. A few years ago, we actually had fun trying to understand what sectors had the most potential. For instance, with the mining industry, there's a ton of tax evasion when a lot of people are saying that they don't have the money to actually finance this or that policy. I think it's actually incorrect. Ultimately, I don't think that the oil industry should always be the one paying everything, but sometimes politicians should actually say, you know what? You're gonna pay. I'm gonna take money from you, period. That's the political will that you need. There's a lot of debate, and maybe you're going to be asking the farmers to pay $1,000, $2,000, $3,000 per month to actually finance their own health insurance system, but at the same time, some mining companies are guilty of tax evasion, not paying 1, 2, 3 billion euros or dollars per year. So I believe that should be the same as what we had 30 years ago, where we wanted to recover the costs, saying that people are going to pay a little bit, and part of it is going to make it possible for the poorest to actually have access to the care. You can't ask the poor to actually finance the care of the poorest, of the very poor. It doesn't work this way. So I believe that behind all this, there's a vision that should be at the national level, if possible, influenced by the outside. And unfortunately, in the sub-region, most of the countries of the sub-region were still very much influenced by modes and donors. This country is, for instance, going to launch a private insurance company because a very important US agency actually started doing business in this area and decided that it was necessary. And there's a lot of money, so we decided that we should have a private insurance system. For instance, WHO is going to impose on Nigeria that some things will have to be done, and we obviously know that it's not doable. Some countries are really strong, some are not, and some are more intelligent. And sometimes you can just say no. Burkina Faso, for instance. Last week we were in Dakar with my colleagues of IRD in order to launch a project because of your minister, Mr. Confin, who had decided that he would use part of a tax in order to finance some things. I believe it was 30 million euros. I believe there's a country that actually said, we don't want it. It was Burkina Faso. We're talking about 6, 7 or 8 million euros, and said, no, I don't want this policy, this free policy, because I'm not ready. Let me plan everything, go give this money to somebody else. And 2 years later, in 2016, Burkina Faso actually managed to launch a policy with its own money. So I believe that sometimes the countries, if they want to do so, can actually guide everything. I want to take advantage of the fact that we're currently talking about Burkina Faso to show you part of a video that you sent to us on the exemption of care financed by the European Union. The objective was to consider the feasibility and the direct consequences on the population of this exemption. Let's have a look. Okay, maybe we can actually show it a little bit later. What's interesting in this video is that it shows an experience from 2012, if I'm not mistaken. So it was not exactly like recently, but what I wanted to see with you is that once we've had this experience, what were the conclusions that were drawn, and how did Burkina Faso actually use this experience in order to go towards universal health coverage? So it's an interesting story. I could talk about it for 3 years. 3 hours at least, but we started in 2008. It's still going on. It's financed by the European Union, and it's humanitarian office that wanted to actually check out how to reduce malnutrition And obviously, access to care is one of the main components of that. And that's why they decided to give benefits to children under 5 until 2012. 12 million euros. It's a lot of money, and I believe that this experience actually showed that West Africa had the world record of access to care, where now you have 3.5 services per child and per year. Nowadays, in most countries of the sub-region, it's 0.5. 0.5 is what the eldest here actually knew when we launched the Bamako initiative over 30 years ago. It means that someone is going to go to a health center twice a year. And for people who have children, you know how many children have malaria and diarrhea problems per year. So thanks to this, we managed to actually increase the access to care, or the number of care services, to 3 to 5 per child, including women delivered a lot more in hospitals. Thanks to this project, which is a pilot project, and the research that was done for a number of years, and we're talking about a research program over 7 years that cost over 1.5 million euros. It's not a small project. It's really about getting the data in order to make the best decisions. And after that, Burkina Faso decided in 2016 to have its own national policy entirely financed by the government in order to implement all of this. And what's ironic is that afterwards, well, you know that in some countries there are implementation problems, reimbursement takes too long, no drugs, etc. The authorities actually had a check monitoring program in order to make sure that it worked. And the NGOs supported the European Union in order to have the monitoring process to make sure that everything went well. And this is something that is currently being integrated in the 2015 policy. The transitional government actually voted a law where it actually included its exemption of payment. So it might be very much different compared to others, but there are a lot of success stories in the sub-region. I believe Burkina Faso probably does not highlight this enough. Next year, maybe you can invite the new Minister of Health, who's also a researcher. I could talk about a lot of horror stories on those free care policies that do not work well, but I believe that we need the courage to actually realize that and understand that, and we appreciate it. Valerie just talked about this control/monitoring process, which could imply that there's some kind of fraud in this kind of system. Is this something that you see, Mr. Obiang, in Gabon? And how do you do it in your country in order to ensure that the beneficiaries are those who should actually get this care?
Well, thank you. It's true that when you talk about health insurance, there will be fraud. We try to provide care to the less favored, but others think how they can make money out of it. So it's true that today in Gabon we're faced with two types of fraud. Social fraud with some subscribers who are not people that do not have money, and we just simulate that they do not have money to get the care free of charge. And in Gabon we conduct social studies to get the specific status of not having enough money. And you know that some are just dressing up as if they were poor in order to benefit from that sort of card or exemption scheme. And so basically we do have to conduct studies where we go in people's houses, and some will invite the persons conducting the survey, and they will invite them in the house of someone else to pretend once again that they do not have enough money to pay for the care. You know that today in Gabon there is a self-financing of the healthcare infrastructures. So those infrastructures do not have to expect the state subsidies. Some of them can be self-sufficient. And despite this self-financing of those structures, there is still a financial incentive to get people to work in public bodies instead of private bodies. And so again, there are also issues around the fees that are being billed for such and such care. And so we need to manage this fraud, because if this fraud is not properly managed, we may have drawbacks from these very nice initiatives that made it possible for the most people to access care. Well, I didn't ask this question by chance. What I wanted to introduce with my question was the second main challenge of universal healthcare coverage. It's the definition of what is a category of poor people, people that are less well off. There are different ways to phrase it, but how do you define it? What is the threshold? And how do you define the ones that should benefit from free care and the others? This is highly sensitive, right? So in Gabon, we have defined people that are destitute or needy, the ones that have incomes less than the minimum wage. So this was the criteria. But there was a confusion in a few people's mind between income and revenues. And so people would say, well, I do not get a salary, when we would ask, do you have an income? Many people that work on markets, for instance, they do have incomes, and they have incomes that are higher than civil servants, for instance, or people working in the private sector. But they are in the informal sector, as it were, and they do have incomes. It's not a salary, it's not declared, but you need once again to capture this informal sector, and those could definitely contribute to the financing of that system.
This issue, which is, as I said, the other important issue when you want to enforce global healthcare in Africa, I want to talk about the definition, really, of who is poor and who isn't. How do you identify these people? How do you decide at where is the cutoff point in this category?
Yeah, that's, indeed, the problems involved with that begin from the definition, as you said, of who is an indigent, all the way to the targeting and actually finding them to benefit. And along the whole chain, there are lots of problems. In the case of definition, we have to realize that societies in Africa are very different from, say, other countries, Europe, obviously today, but even Asia, which is closer. Pre-capitalist systems in Asia were more stratified, very highly stratified. People belong to a caste or a particular social group, and it's clear. In Africa, the pre-capitalist systems were not so stratified. They have been, in effect, because of modern development, it's gradually getting more and more stratified. But to identify a poor person, to say someone is poor, let's take the Ghana's definition, and I've seen this same problem in other countries. I'm just using Ghana as an example because it's my country, but I've seen it in Senegal, in Nigeria, Tanzania, and so on. In Ghana, they said the poor person is someone who is not got any source of income, who has no home, and has no relation upon which they can depend for income. That's not possible in Ghana. You can't find anybody like that. In fact, the joke was that the only people who can be identified really under those criteria will be the beggars in the streets of Accra. But if they are beggars, they will never even know about your scheme, so they can't even come forward. So there's no way you can identify anybody under those criteria. We had an exemption policy which actually failed before because it was trying to use the communities to identify, but the incentives also were such that people were incentivized to exempt people who were not poor because they just wanted, to ensure that they don't pay anything at all. So you have that, and then you have the targeting problem, which is full of also incentives that are perverse in terms of, what's the mechanism for actually targeting them. The bureaucracy, as we know in Africa, is poorly placed to identify poor people in the communities. They just aren't equipped to do so. And people have an incentive to deceive them, because they don't trust them. And that is quite, a widespread phenomenon. So you have a great difficulty with identifying people. And these mechanisms of identifying poor people, means testing and so forth, have failed time and time again in Africa. And I think that it's really time to actually ignore those ones and to begin to think more proactively about whether you want more universal systems or geographical, systems of targeting and so forth that do not require a bureaucrat to identify a poor person. Otherwise, you always face this problem.
Valérie, vous vouliez intervenir.
Valerie, you wanted to intervene. Yes, indeed, because it is a topic of research for me for more than 20 years. And this is what politologues or experts in policies, this is a lot of talking, basically. We've been talking about it for 20 years and nothing happens. How can we target the most needy? There are many mistakes, and I know that it's expensive for a bureaucracy to do the right targeting. And then we come back to all the concepts of public health, through which we try to make a distinction between universal and targeted approach. And now what we're talking about, what is very fashionable, is to talk about proportionate universalism. So for those of you that do not know what I'm talking about, it's universalism, but with a pinch of proportion, which comes to say that everyone should access healthcare, but for some people, and then you have always the targeting problem, some should get more. So we heard about putting things in commons, about those mutuality, through which you pay according to your needs. But today what's happening is quite the contrary. To my knowledge, there is no such mutual endeavor through which people pay according to their means. In Senegal, I know that there is a 50% subsidy to be a subscriber to such a scheme. So that's really one of those problems. You don't really pay according to means. Therefore, I think it's high time that we try to go beyond all those speeches and in trying to beat about the bush and try to define who's destitute, who's needy, and really try and find the right approach. In the field, people don't necessarily know that there are some solutions out there, and many people are not aware that they can get an exemption for payment. You know that when you need to get drugs, then you first need to put fuel in your motorbike to ride to the city, and that's something that you have to pay already. So I think that we should avoid being trapped again by knowing, well, who's poor, who's poorer, who's needy, and really we should try and avoid compartmentalizing society or creating categories. Diane, you wanted to say something. Well, yeah, going to try and reply in French. In fact, those mutual with a community basis are not sustainable if they are not supported by the government or by one level of authority. Because when it comes to capacity, but also when you need to mobilize the right resources, they are not sustainable. Usually those mutual with a community basis bring together people from the informal sector. So when it comes to identifying and creating categories within those population, it's very challenging. MCF tried to support some category of people based on their incomes in the informal sector, but the problem that we're faced with was to really define the threshold at which a household can be defined as needy or not needy. There is an experiment in Rwanda where people would subscribe to such an insurance and they would pay a flat fee. And we realized that it was some sort of regression, because a poor person would pay the same fee as a wealthy person exporting coffee, for instance. So we went from a flat fee to a category, and we have somehow to create categories in the population based on their ability to pay for their insurance. And there is a homegrown solution, as we call it, with a participative approach. And the government in Rwanda, with the help of the local administration, implemented a participative scheme, and people are split in different categories based on incomes. Right, so neighbors contributed to saying, oh, I think that one belongs to that category. Yes, this prevents people to go to the village and be identified in the village as a poor person. So again, there's a connection with the identity card. So you have the identity card, and then you have a database through which you really define and identify those who are in need. And so those more destitute persons pay less than the richer. And so there's, of course, solidarity. Obviously, it is complicated. There are many informal aspects, and so we need a very close follow-up. So I think that would be my first take-home message. So we need support. Now, when the most needy have been identified, then we need to implement safety nets, not to lose them, because we realized that those, even when they have an insurance, there are still financial barriers, because you have to pay for transportation, you have to finance co-payment, and also this is a financial barrier, or this is going to create a very high expenditure. So we need to try and find those safety nets, the social safety nets. Try something else to try and find the right balance between and get to cross subsidization. So the right balance between private and public sectors, with a share being a higher share being paid by those that have more money or more financial means. And we should also try and avoid adverse selection. We have a regulation through which every people living in a city or in a village have to subscribe to an insurance. So whether it's a community-based insurance or a private insurance, in that way the government tries to, well, if the law is properly implemented, the government is really implementing those safety nets. Well, thank you. I just wanted to reassure Valerie by saying that when we assess the behavior of policymakers in Africa, they start things. And it's true that there's nothing like a perfect definition. We have to start with something and then slowly adapt, because there are economic and social constraints. And as I was explaining, there is no perfect definition. Who is destitute? Someone who will say in the face of a public body that they do not have money. However, those people would go to a traditional practitioner to pay for a hen or to pay for a bone to get the traditional medicine. So in some neighborhoods where people are not so well integrated with you would be surprised by a Canal Plus coverage. You get antennas everywhere. Same thing with mobile phones. Nowadays, everybody have a mobile phone. Therefore, we do have this problem with e-definition, because those people have a problem paying for their health, but not for their mobile phone. You know that for an African person, you're in good health when your organs are silent. So an African person will not go to the hospital for prevention purposes. So if we do not go to the hospital for a checkup, then of course it's difficult for them to understand why they should pay when they are not ill. And those are cultural differences that have to be taken into account. However, we shouldn't think too much about it. We have to start. We have to kickstart the process, which is what we did. And we adapted as we went. So the threshold is the minimum wage, and now we're taking into account other things. For instance, if people have a subscription for Canal Plus or have a subscription for a mobile phone, then maybe you should increase the threshold above the minimum income. People, workers, whether they are workers or needy, everybody should benefit from the same health coverage. And it's true that when you have cancer, you should benefit from a coverage, and you should benefit from the possibility to be treated abroad. Well, first of all, I'd like to apologize on behalf of Canal Plus for being cited. I'm going to give you the microphone in a minute, but first of all, I'd like to pick up on something that you said, and I think was very important. Somehow, you implied that there are things we do that we have to arbitrage, and that there are things that we do despite the fact that we have few financial means. And it seems that in the choices, health doesn't come first. I know that you wrote a book on preconception about health in Africa. And this notion that when you have a choice, you're not going to invest in health, but rather in a mobile phone, is it something that's true in Africa, or is it a preconception? That's an excellent question. I don't know. If you have a choice, I don't know if you're going to invest in health. You know, in the villages where I work, in Burkina Faso or Mali, there's no power, there's no television, there's no Canal Plus, there's no mobile phone for that matter. So I think that the people that are in such a situation, they have no choice. And when they go to the health center, they will get a community healthcare professional with few skills and few means. And you know, the people have no choice. But I think that when it comes to decision making and the way programs are being implemented, I think there are many preconceptions and ideologies. Not so long ago, there was a professor in gynecology who stood in a room with 300 people, and he said, well, beware, if delivery are free of charge, women are going to have more children. And of course we know this professor was so well known and had such a statute, nobody interjected, nobody opposed that statement. But there are many preconceptions like those, and people think, well, if we give a card to destitute people to get treated, well, they'll abuse, or people that are going to get universal healthcare coverage, they will abuse that system. Well, maybe so, but we need more training. We need to raise awareness. We've seen the debate lastly on mortality in Africa, which is based on nothing but words. And again, you know, I'm a researcher, but I think there's too little research. And there are also research that are not widespread, that are not disseminated. People and researchers are incentivized to publish in English-speaking magazines that most people can't read because they don't read English. So, you know, research is being ordered. That is not useful. And I received many messages from NGOs or from mutual insurances, and they're asking me, well, why wouldn't you conduct a research on the reason why people do not want to subscribe to our insurance? You know, at the end of the day, we need to be able to think collectively, and we should try to pool the resources so that the resources are made available to as many as possible. And also researchers should use the appropriate words. There are still people out there that make presentations with PowerPoints and slides that are so busy that the regular citizen can't understand what they are talking about. So if you use words that talk about epidemiology, anthropology, economics, it's not helping in disseminating the message. So we need to make a connection between the programs and the field and research. And again, people do not read what is being published out there. And again, the responsibility doesn't lie with the researchers nor the policymakers. It's all our responsibility.
You can continue because I was going to go back to the indigent issue. I think we are going further now.
I would like, well, since you wanted to intervene, you can grab the microphone. I'd like to hear you talk to us about the universal health insurance scheme that has been put into place in Ghana. Ghana was a pioneer African country in this aspect, and you've experienced this implementation firsthand. So can you tell us about it?
Yeah, so in 2003, after a period of years when the mutuals were developing and really blossoming in Ghana, the government set in motion a system called the National Health Insurance Scheme, which was based upon district mutual organizations. So the initial law in 2003 defined mutuals based upon the district, which formed the basis of the National Health Insurance Scheme, with a national level authority that was managing the whole scheme. And these mutuals at the bottom had their own boards of directors and staff and budgets. But in 2012, this system was actually abolished, and we now have a more centralized system run from the national level. This, the UHC project at the time wanted to cover everybody at once. It was pretty ambitious. I mean, that's why Ghana is fascinating, because it was highly ambitious at the time for a country in that level of development to say we want to cover everybody at once. And not only that, but that we have just one scheme. You know, this is actually unique in Africa. There's only one scheme in Ghana that you can belong to. It doesn't matter whether you are in formal sector or informal sector, you are a director or a laborer, we all belong to one scheme. And that is different, that's actually very new. And not only that, but you all are entitled to the same package, obviously depending on your demographic and so on, other, your needs. But you are all entitled to the same benefit package. That again is also new. There's no country in Africa where everybody has one benefit package entitled to that, no matter where you are. So it doesn't depend upon how much you pay. Your package is dependent entirely on your needs. So it was clearly very ambitious and clearly best practice and well ahead of its time. But the weaknesses were clearly very clear because you can't. I mean, again, the benefit package was very, very generous. Was people say colloquially that 95% of the conditions that affect Ghanaians were covered. There are very minor exceptions, which are basically even related to ARVs and acute dialysis, which are renal dialysis, which are related to actually conditions that are covered by some vertical programs. So in reality, it's like the sky is the limit. That was one of the issues as well. The contribution was only the formal sector and informal sector adults who contribute. Let's say if you are above 18 and you are in the informal sector, and if you are working in the formal sector, you contribute. I mean, the formal sector, they contribute through indirectly, because 2.5% of the social contribution is, 2.5%.
Just so I understand, are you saying that the financing was entirely domestic?
Yes, it's 100%.
Okay.
Yeah, the Ghanaian system was 100% financed domestic. There's no foreign money at all in it. This based upon the innovative element, as I was talking about, was the 2.5% VAT. That 2.5% VAT is actually substantial in Ghana, because it's everybody who buys goods and so forth is contributing. So that actually contributes a mass of money that is in principle sufficient. Then you have 2.5% of the social security contribution of workers, which is also put into the insurance. And that is supposed to be the cotisation, the premium of the informal sector, the formal sector workers. And then you have the informal sector adults as well, who pay a premium of about $5 per year, it's quite small, to join. The exemptions are huge. You have all children up to 18 years are exempted. You have all retired persons, retired. You have pregnant women. You have old age above 70. All exempted, including the formal sector, because of the social security contribution. They don't pay when they join. So about 70% of the membership really doesn't pay at the point of joining, no contribution at the point of joining. And in fact, at nearly half of the membership is actual children under 18. Everybody make sure that their children are registered. So that's really the system as it was designed, at the beginning. And the challenges are more to do than the viability, the sustainability of that.
Yes, because you, if I'm not mistaken, you conducted a review of this scheme. Yeah. What were your main conclusions?
Well, the main thing was that, first thing, that for a country at our level of development, the first thing should have been to look at what are the priority health problems of Ghana, and what, therefore, can we do to, because if you look at our indicators, maternal and child, mortality are not good, even up to now, despite the insurance scheme. Really, even the maternal mortality in the last couple of years is actually going in reverse. So it's really very bad. And so we said, and in fact, we found out that even for the insurance scheme, about 70% of the cases are related to 3 areas: infectious diseases, non-communicable diseases, and pregnancy-related complications. Just tells you that really, if you look at it in terms of burden of disease and the priorities of the country, we should be investing in primary health care, because you can actually make a lot of difference in, for those areas by investing in primary health care and prevention, promotion. However, the National Health Insurance Scheme is curative care biased. It does not finance prevention. So in effect, we're actually paying with all this money for the consequences of the bad performance of the health system, since we don't have a very good public health system, And that is perverse. So we thought that we really ought to go back to the roots and to say, let's say, after all, the VAT is paid by all Ghanaians. So why use all our money to pay for only 40% of the population? You can define a package, primary healthcare package at the bottom, which is available to all Ghanaians, 100%. But above that, apart from exemptions, maternal and child health, which are priorities because of our indicators, everybody else should pay the insurance premium. And that premium should be more realistic than what it is now. So that's really basically what our recommendation was. First of all, to actually go back and redesign the benefit package. We didn't say reduce the package, because that is politically sensitive. We just said put the focus on this, and then look at ways in which for instance, through budget neutral mechanisms, you can contain the cost of the higher level of the system. That will require perhaps a lot of rationing, and so forth. But nevertheless, rationing exists even in the developed countries. There's nothing wrong with that. But we should contain the costs of the higher levels. And we actually did a calculation because we said the primary health care package we're recommending should be based upon capitation. So which means that, currently we have a capitation system where people pay 1.5 cedis per person, the insurance for capitation. If we say you expand that even to 2 cedis per person to include prevention and so on, we calculated that you need only 2/3 of the revenue of the scheme to provide this primary health care package for the whole country. So really it's doable. Now the 1/3 left, we have to then see how we prioritize with maternal and child health at the higher levels and exempted indigents and so on. And then raise revenue sufficiently, especially from the formal sector, because I keep challenging our formal sector people. There is no country in the world no other country in the world, where workers contribute only 2.5% of their salary to an insurance scheme. It's a joke. There's no way you can get a good package of health care. Health is very expensive, and we need to face that. So 2.5% was not really realistic. Even our neighboring countries, Nigeria was supposed to 15% of the salary divided between employer and employee. In Rwanda, it's definitely 15%. So why in Ghana are we paying 2.5%? Because of the deception that the 2.5% VAT was enough. So this is some of the problems I was talking about, and so on. So we need to be realistic. For the higher levels of care, workers should now pay a more realistic premium to cover their health care. But everybody will be entitled to a base package of primary health care.
Thank you. Actually, a question popped to mind while I was listening to you, and I'd like to ask you, Diane, peut-être en français, je ne sais pas ce que vous préférez.
The states, the African states that rely heavily on international funding to implement the UHC, do you think that it's a sustainable approach?
As I said in the beginning, the financial sustainability is a big issue. Actually, WHO is promoting thinking about innovative ways of domestically mobilizing resources. For instance, maybe some countries initiated the tax-based financing, although in African countries, even the tax base is small, but somehow it's something that can, the health financing or universal health coverage strategies can rely on, especially that they are more flexible in terms of socially sustaining the needs of the population in terms of health, financial access. The other way to mobilize more resources domestically were to engage, because we felt, we saw the available literature show that the private sector is not optimally engaged in this process. So the public-private partnerships. And also, as my colleague Chris said, we need to ensure that those who can pay among the population should pay at the level of the way they can, and ensure that no one falls, pay beyond his or her capacity. So it's very important that we all identify ways, different ways to mobilize domestic resources. And here it depends on country contexts. So it's important that we first understand the context and now define. Different efforts are being made. Countries have engaged in defining health insurances, like private insurances in the Southern Africa, but it's important that the formal sector is not left behind. So we support in this spirit to define strategies to ensure that even the informal sector is covered. And where initiatives such as tax-based with specific identification or targeting of the informal sector, this is a good path where now sustainability remains the high priority, and it's as I said in the beginning, it requires strong systems, health systems, in terms of governance, in terms of how they use the available resources. For example, previous years, the funding was input-based, as I said, and now we are trying to encourage countries to think about performance-based funding, which is more helping the performance itself, the efficiency in the use of services.
You would tend to support this.
Yes. And also the pooling, because, for example, there are many initiatives. It's important to try everything, but pooling resources, trying to help, to engage with partners, avoid some duplications. There are many duplications, like a specific partner brings in money with the structures to manage and to report on these. So these fragmented way of reporting increase even the transaction costs, and we are trying to support countries to see how they can work in a sector-wide approach, to maybe have unified ways of managing resources, external resources, and also within the existing national or country systems to see how to pull together resources. For example, we have community-based insurance, social health insurance. How can they work together in terms of cross-subsidization, but also unified ways of managing? If I may give a little example, when Rwanda moved from the community-based health insurance was moved to the social health insurance. We have now 30 administrative districts, which each one were having a community-based health insurance with the specific management structure. Now everything has been unified in one, and it is located in the social health insurance in Rwanda. Thank you.
Valérie, vous souhaitiez réagir?
Oui, c'est juste réagir sur cette question de financement basé sur les résultats.
I just wanted to come back to this issue of financing based on the results. Rwanda is almost a success factor. We often forget that we have one solution and we want to apply it pretty much everywhere. That's usually what people want. I don't know about Rwanda, but the context is different. We have a strong government, a social government that is also very strong, and you don't really have the choice not to be a member. I work in West Africa a lot more, in Francophone Africa, and financing based on results will work because you're motivating the staff if they work well, but also you can have sanctions if they don't work well. In the regions where I work, obviously, there are no sanctions. The worst that can happen to you is that you're sent somewhere else. I mean, that's the worst, but not worse than that. So the social context is totally different, and basically we have a solution that has not proven itself to be efficient, and we want to apply it everywhere. And we want to apply it because there's a lot of money in Burkina Faso. The World Bank actually got there with 30 million dollars, and we're talking about millions of dollars, and this is not even proven to be efficient. They just did it in Mali, 3 months in 10 different districts. I mean, we could talk about it at length, but ultimately I believe that we would need to have innovative solutions that we're going to test, but we also need to adapt them to the local context. That's basically like the carrot that you have in front of you. In our context, it's not the carrot and the stick, it's the carrot and the carrot. So how do you possibly do this in some of the countries? On top of that, these approaches are fresh money, it's extra money, $30 million extra in a country. It's going to work. I mean, if it doesn't work, then you have a problem. But who's going to take advantage of it? It's the healthcare professionals. It's not the population with better care and better access, because you're constantly asking the user to pay at the point of service. So that cannot work. And ultimately, people are extremely happy. The healthcare professionals are happy because their wages have been quadrupled during the pilot test. And they're used to this kind of project because for the last 30 years, we came with our Jeeps and our stickers. We say, okay, I'm going to do this, I'm going to do that, and we speak a lot, and we actually say, you know, it's going to be something new. And I can't say what it's going to be because I'm not a visionary. But anyway, people are not crazy. There's a district called Boboi in Nigeria. It's close to the capital city, but it's rural. So all international experts always go to this district because they can test a number of things, and then they have Canal Plus, so in the end I can actually have a look at this channel at the end of the day. But this project, I mean, this neighborhood has been a pilot neighborhood forever. What do people actually think about that is the question that I'd like to ask. We've done a number of things over there 30 years ago. And now, over the last few months, the World Bank has gone and actually decided to do something new. So it's a lot of capitalization, but nobody's actually thinking about the conclusions. We could have another debate on this. Thank you very much. Thank you to all four. I want to give you the floor if you have any questions for our speakers.
Comme vous avez levé la main en même temps, je vous laisse choisir qui prend la parole en premier.
The floor is yours. I'll let you decide who wants to talk first. Very quickly, I would like to ask the panel how they perceive the way the international community actually got organized around what is called IHP Plus in English, the International Health Partnership, that brought together all the partners to work together with just one counterpart and to optimize the approach. So Valerie, then Chris maybe? Well, the FBR in Benin, one example. Currently you have 3 donors that have shared the country together between those 3, just like at the Berlin conference. So you have Gavi and the World Bank, Belgium, and then the third one. And basically they tried to harmonize their work, and they managed to do absolutely nothing. Everything's falling down. There's no coordination. There's been no coordination, no leadership in order to ensure that it could work. And it's currently stopping, and it's going to be a disaster pretty soon. So it's a bad example, but I can give you good examples. Maybe my colleagues can actually do that. IHP Plus is helping the countries to develop the countries with health plans with attributes that are clear, among which you have participation of the partners, of the stakeholders, and of the partners in defining the priorities. And once everything's gone through IHP Plus, the strategic partnership is much more reliable because it involved everybody's participation. Second, the alignment of the partners on the country's priorities. There are many challenges for this alignment to happen, including in the financing, the implementing, and the monitoring They promote unified structures one way or another. For instance, putting all the funds together in just one pool, that's one of the processes. They have some partners that agree to that, others are much more unwilling to do that. When it comes to the support they give to the countries, so it's one of the structures that actually favors advocacy, participation, and local capacity building, increasing trust, and possibly the opportunity to finance within the tool and unify. Basically, it directly reduces having a needing to use different monitoring systems, including at the local level, where it's very difficult to meet the needs of every single partner. So AHP Plus helps the countries and even the key partners like the Global Fund, Gavi, the UN agencies, and some bilaterals have signed kind of agreements called compacts with IHP Plus, so that if a strategic plan went through the IHP Plus plan, for instance, a national health plan project, well, instead of designing individual different little projects, you can actually go through this directly instead of having to assess different things. That's what IHP Plus brings to the countries. It makes it possible to strengthen the technical capacity in the countries and possibly get results. Thank you. Thank you, sir. In Gabon, we're not really subject to this initiative because we are a middle-income country, but the few shareholders that are active in Gabon, I would say that everybody is preaching for their own vision. The partners like to have a sticker here, show a little bit of everything to be visible and show it to the international community that something's happening, that they're doing something. And right now, they have requirements that are not adapted to the local context. For instance, sending monthly reports to remote areas where the little boat or the car will not even manage to reach. There is a way to actually adapt everything. There is the reality that you have to take into account. In Gabon, health is financed up to, I would say, 99%. Health insurance is actually financed 100% by the Gabon government, but it's first political willingness. Africans need to embrace their own problems and look for solutions in order to make it possible for the populations to get access to care. Programs are dangerous, 3 years, 5 years, but as soon as the partner is gone, or as soon as the Minister of Health is trying to steal some money, you have a problem and the partners are gone. So I believe that the national context and the local context is very important also. We started just like in Ghana. However, currently, whether you contribute to it or not, universal coverage is the same for everybody. There's no discrimination between the contributors and the non-contributors. It's all about the political willingness. The poorest, we finance them thanks to the telephone provider tax. We realized that it wasn't sustainable over time, and the government decided to find a new indirect tax, which is a VAT tax. And now I can say this. In Gabon, when the health insurance actually started, we had no more glucoses in pharmacies because people who didn't actually have the means to get treatment went to the official healthcare, to the hospitals and clinics. As you know, in Africa, we don't have enough drugs in hospitals, and so we worked with private entities that did everything that was possible for the patients to actually get the drugs in their pharmacies. And so this partnership made it possible to improve the income, the turnover of the private structures, and currently we have pharmacies that are expanding, and this is the kind of thing that should be shared because it's really enriching. Thank you very much, all three of you. Yannick, did you want to say something? There is a question that I was wondering, and I don't know how to actually ask it. Based on what you said, it looks like there are different series of economic channels. Basically, whatever is happening pretty well. Motorcycles, cell phones, television. You never really needed to have a program in order for phones to start spreading, and then it's nice because you can have a tax, and there you go. It's nice because in the world, the cell phone, and I'm doing short, is perfect for the reticular system in Africa. So that's perfect. And then you have financing. You have the money circulating, which ultimately you didn't talk about a lot. 20 or 30 years ago, there's an anthropologist that actually compared the money spent in health with the money spent to seduce young girls in some countries, and it was actually a lot more than in the health system. We're not going to find 70,000 CFA francs, but we're to do a C-section, but we're going to find a lot more to bury her once she's dead. So it's an endogenous economy. It's an economy that knows how to create some systems in order to find some resources. And what's striking in what you said is that this health, or the money dedicated to this health, is for historical reasons, because health came from somewhere else, or at least this one because money for traditional practitioners, etc., is something that can be found, or from somewhere else. It's like this modern health is not socialized, and because it's heterotopical, meaning outside of these societies, it's like we couldn't find the financing necessary or that can go with this kind of society. And it feels like no matter how hard we try, as long as this health system is not integrated, accepted by the social system, you'll never have the necessary resources. That's the way I'm actually looking at all of this. But it is a question that I asked, but I'm pretty sure there will never be an answer to this. Right here. The gentleman. Oh, okay. I saw the gentleman who wanted to ask a question right here. To support the speaker, I believe that we needed a lot of courage to talk about the financing of health, because it's a taboo topic, and it often is a source of concerns, sometimes even controversies. I believe that right now the question is how to have a sustainable universal health coverage in Africa. Everybody agrees that we're going to have two finances, to finance it, but ultimately the problem is governance of health. There will be as many types of financing systems as there are health governance systems. And behind all of this, it's the issue of governance in a general manner. We cannot have the same approach in terms of financing absolutely everywhere. Currently, when we're talking about financing, it's all about controlling the cost. In Africa, when you're talking about financing health, you disagree on the method. Why? Because there are huge differences between the countries and economic disparities between the countries. Some countries have a very basic economy, others have a primary, secondary, tertiary economy. In some countries, the formal economy is much more significant than the informal economy. Who's going to end up paying? The individual, the government, the community? When you go to Touba in Senegal, there's no financing problem for health because the community is financing it. So that's number one. Number two, wealth. So like I said, number one, wealth and the structure of the economy. Number two, who do we want to cover? We heard different types of coverage, universal coverage. Then we talked about covering the poorest. These are very different types of approach. In one case, you cover the whole population. That's what's going on in Europe. And in the second type, it's all about including everything. But financing will be only for the poorest. And also, how do we categorize the population? Are we going to cover all areas, all geographic areas? Are we going to cover only those that do not contribute? Finally, we haven't talked about pathologies like programs against malaria, tuberculosis, etc. So it's antinomic in a way. For UHC, do we want to cover pathologies and endemics? Also, something else is the organization of the health system in the country. And finally, I would take the example of a country that we often talk about in the pharmaceutical world as being exemplary in terms of access to the population to care and services. It's India. Look at India right now. Do you believe that in India you have a homogeneous, universal access to care? We shouldn't work on just one parameter like drugs or one parameter like financing. Everything has to be homogeneous, but financing will obviously follow the money and wealth. So you have to accept that the forms of financing will be different, that they are smart, that they are different from one country to the next, because the effort is going to be proportional to wealth. Thank you. Thank you. I would recommend that we accept one last question, because otherwise we're going to start with a new round table. But these are all very important questions. I'm with Le Monde Afrique. Two questions very quickly, because I promised. One of them for Mr. Ridde. We talked a lot about the financing linked to performance. Do you have any examples? I believe that you probably have a lot of perspectives in Africa, because it seems to be a system that is pretty limited on a number of issues, and that's part of my second question. In many African countries, they are constantly pushed to follow programs that are linked to pathologies or specific health issues, and don't you think that it actually goes against a global healthcare system? So small question, 2 minutes, right? But the issue of FBR in Africa is obviously a question. It has been for a long time. A number of paper documents have been just published on the UK that is actually the most advanced one in this regard in Europe, and it actually shows that there's been no impact. It's good that the people actually use the services, but if it doesn't change anything regarding to life expectancy, so basically it has no impact is what this just showed. Now, regarding what's going on in Africa, we still have too few data on the use of care. There's a lot of debate on this. In Rwanda, there was a document that was published at the beginning of the 2010s that showed that it worked pretty well, but then 5 years later, after a new analysis, it seemed that it didn't work as well as we thought. So it's difficult to do studies on this kind of topic, and we have very little information on these subjects. But FER is less of a problem when it comes to the coverage of complete coverage of health systems, because some donors will decide to do FBR for HIV, others for maternal health, etc. And usually they have an impact on demand or offer. The day we'll be able to actually create a world fund for the strengthening of international healthcare systems, we'll have done a lot, because this way we'll try to understand how we can work on all of this at the same time, instead of drugs in one country or access to care in another one, or this in yet another country. And obviously capacity building is important, or rather system strengthening is probably something that should be worked on as a whole. Mr. Obiang, one last answer, and then we'll close. I just wanted to say that success of this project is linked to strong political willingness, based on what you just said. Let me take the example of insurance. If we didn't have penalties and sanctions, we would all be insuring our cars in an optional way. We don't have accidents, why insure your car? So health insurance, if we want to implement it, it has to be mandatory. If it's optional, then people, based on their situation, will decide to do it or not. But don't worry, you know, in villages, people do not get a private insurance thinking, well, if I get sick, then I will get money to fight against it. That's not the reason why. I believe it's a change in the mindset. We need to explain all these initiatives that we are doing, and the elected officials do not talk to their population. We need to explain the rationale of all these initiatives for better compliance, because otherwise people are going to think that it's for electoral purposes, it's because of financial purposes, etc. And sometimes it doesn't help and doesn't encourage the population to actually be a believer. Okay? Great. I felt that it was a perfect conclusion. Thank you to all of you, and I believe I can give them a warm hand.